All right, well, let's head into it again with thanks to each and all for really splendid foresighted and farsighted remarks and conversation. And now we're going to move into the discussion of federal policy and governance considerations, the notion of how to position facilitative policies has been a sub-theme throughout the entire meeting, and the emphasis is on ensuring that we have the safety and security of those who are our primary clients, if you will, the whole patient population and indeed the whole healthy population of the nation as we work to ensure that the possibilities not only for enhanced mobilization of the most sophisticated insights, but enhanced opportunities for democratizing, I think the word was used earlier today, the kinds of interactions of people with their own health and health care is going to be dependent at some level ultimately on how agencies that are governmental in nature or agencies that are industry-wide in nature position themselves. And so a fundamental part of our interest is beginning to understand from the perspective of this meeting a little more about the dynamics in play. And we had a nice warm-up with the last session, and now the session that we're turning to is going to be moderated by Troy Tasbez. And Troy is the Director of Digital Health at the Food and Drug Administration. That's a very handsome picture there.
Let's try to touch that up a little bit.
He leads the Digital Health Center of Excellence unit, which is responsible for enabling digital therapeutics and technologies that contribute to the ongoing modernization of healthcare in the U.S. This vision is enabled through technology evaluation, clinical and integration strategies, policy development, and strategic partnerships. Before joining FDA, Troy was at Oracle for 11 years, holding a variety of technical and business responsibilities for building and scaling the cloud business. So he sees this horizon from a variety of perspectives through different lenses, and you're the perfect person to facilitate this. Troy, thank you very much.
Thank you, Michael. And this is, by the way, the before joining the government, and 10 months. So just kind of start things off here. So, it's what, I'm sorry? Yeah. No, I think I get called Tony or Todd all the time, but so. No, so thank you all for having us. And I just want to also say thank you to NAM for bringing together such a wide range of expertise, knowledge, and thought leadership into a place. And I want to echo what Victor really said here. It's not really what we talk about here, it's what we do from here on out that's going to really matter, particularly with a topic this complex and evolving. Now, I was told that we're running quite behind, so I'm going to try to cut my remarks extremely short so we can effectively get to the panel itself. But, I think today our conversation is going to be around government's perspective of how do we actually regulate this. And this is a very complex topic. It's a hard question to answer. And generally speaking, when I get asked about, hey, we need you to regulate us, I respond with, great, how? And that usually stops the conversation, and I think that's the problem right there, right? So now, what I do want to also say is that I think that innovation cannot be mutually exclusive from this concept of safety, right? And how I've been really talking about it is just more of it's innovation within parameters, and I think that's what we're here today. I mean, we're in this crossroads of there's this great innovation that is happening, and we have to apply it so carefully because this is also a very critical industry. that we're trying to solve some very critical problems of. And so what I want all of us to think about is that this is really not, from a governance perspective, only a federal government has to think about this. We have to collectively actually come together and say, how do we actually apply this in a thoughtful manner and using prioritization in its application, right? We talked about that, and I alluded that earlier in the sense that I think it's the industry's responsibility to truly work on the product management discipline of here are the priorities that we have to effectively start with. And that's essentially what we would like to talk about. We have a great panel today. I'm looking forward to hearing all of our perspectives. Gil Altrovitz is the inaugural director for artificial intelligence at the U.S. Department of Veteran Affairs. Based in the Office of Research and Development, Dr. Gil Altrovitz is working on leveraging health information for AI, as well as building AI research and development capacity to help our nation's veterans. Dr. Altrovitz is one of the core authors of the White House Office of Science, Technology and Policy's the National AI R&D Strategic Plan that was published in 2019. And he has also spearheaded the AI-able data ecosystem pilot, creating a new approach for public-private collaboration with personnel, resources across a dozen agencies, and working with companies internationally, and it's been a great partner to work with. Next to him is Robert Valdez, was appointed the director of ARC, or AHRQ, in February of 2022. He was previously the Robert Wood Johnson Foundation Professor Emeritus of Family and Community Medicine and Economics of the University of New Mexico. From 1993 through 1997, Dr. Valdez served at the U.S. Department of Health and Human Services as the Deputy Assistant Secretary for Health and simultaneously Director of Interagency Health Policy before joining DHHS in 1993. He served as the Special Senior Advisor to the Clinton White House on healthcare reform. Next to Robert is Riva Schwartz, is a research scientist in the Information Technology Laboratory at the National Institute of Trust Standards and Technology, where she serves as the principal investigator on bias in artificial intelligence for NIST's Trustworthy and Responsible AI program. Her research focuses on evaluating risks and impacts of AI systems and improving organizational practice for managing these risks. And then we have Catherine Marcassini, serves as the Chief Privacy Officer at ONC, where she advises the National Coordinator on matters related to health information privacy, security, and data stewardship, especially as these issues impact IT development and implementation. Ms. Marcassini works closely with other HHS divisions and federal agencies to assure coordinated nationwide approach to maintaining the privacy security of electronic health information. And Christine Coutillo is the data science lead in the Office of Director of the National Center for Advancing Translational Sciences. In this capacity, she works with offices and division across NCATS to strategically plan and drive successful operation of data science activities at the center. She also works on collaborative initiatives to advance translational science, particularly data-driven projects in the area of rare disease and artificial machine intelligence. International efforts to advance the science, understanding of biomedical, translational will shape the future of AI and ensure remains a force for good, benefiting society at large while minimizing the risk it possesses. Now I will pass it on to Gil.
Great to see a lot of familiar faces here. Just a quick update actually. So I have a slightly new position. I'm Chief AI Officer at the VA and Director of National Artificial Intelligence Institute at the VA as well. So we're going beyond research and into operational use cases. And I'll talk today a little bit about the federal policy and governance, and I know there's a lot of interest in generative AI, so we'll talk a little bit about that as well. So we'll go to the next slide here. There we go. Well, this slide isn't meant to really be read, but just to see that there's a long list, essentially, of different types of guidances, mandates. There's also congressional items, and I think, as some of you know, we'll see some things coming up pretty soon as well. And what it really means is that there's kind of a need to look at how all these pieces fit together, right? Because we see different pieces from different parts of government. We have some of these speakers here today, like from NIST, right? There's the AI risk management framework from, you see here from the White House, from OMB, from Congress, different acts and so forth. And international, I don't know how many of you are involved in the international sphere, but OECD has these recommendations that have actually the U.S. has signed on to is binding for us. So what we've done at the VA, so just a little background, the VA is actually the largest civilian agency, depending on which metric you use, of course, but we're the largest integrated healthcare system in the United States. Although there are actually facilities from the Caribbean to the Philippines, interestingly enough. But and so given that there's a lot of data that can be used for our mission, right? Over 9 million veterans that are in the medical records that we can serve through AI and leveraging it in a responsible way. And so even though we're not technically a regulatory agency in that we're not regulating things in public, any policies that we do influence directly, these 10 million or so individuals very directly, right, their lives in terms of both the healthcare benefits and so forth. And so we set out a couple years ago to create a VA AI strategy. We're actually one of the first agencies to do that, and brought together over 20 some offices. Right, the VA has a number of different offices that leverage AI or think about AI in different ways, and we helped kind of bring them together by creating first an AI task force and then an AI working group through the VA Data Governance Council. You can see that strategy if you'd like at this website here, and we've been looking at doing things proactively that I think you'll start to see. For example, I think I mentioned, for example, creating this AI work group, creating officer and types of appointments to move this forward. In a way that, with the intent that we're going to proactively do the things that before they're necessarily perhaps required to be done. And as part of that, we also created a VA agency-wide trustworthy AI framework. So we're really committed toward implementing a unified trustworthy AI framework, right? Leveraging all those individual tools, those pieces that I mentioned in the first slide, and then adding in some of the things that are VA specific. And we're thinking that is a good way to move forward in the future, right? Because agencies like ours, we have a certain mission, which means that we will leverage those general frameworks, but add in then those VA-specific items. Like we have a data ethics framework and things like that. All those were integrated into this trustworthy AI framework that was announced at our AI Summit in September. I know I've seen a number of you there, and we had the Secretary announced that agency-wide trustworthy AI framework there. It's been leveraged. A number of organizations have looked at that as well. And actually, you can look at it if you'd like. There's a page there. And it's actually on our new website. We have a new now department for the whole VA. There's a kind of an AI website that was launched in September. So you can read about the trustworthy AI framework, but also on other things related to AI. We put up our list of AI use cases. As you may hear from some of the others too, there are also now requirements and to put up an AI inventory of the different use cases and how they fit in terms of trustworthy AI. And so that's one of the other things that you can see on the new website, department.va.gov/AI, that we launched in September for this unified view. In terms of leveraging governance, right? So we set up some governance structures, and that's kind of what we're working on. In fact, today is setting up some of these structures, and I think setting up governance is really a prerequisite towards some of the next steps, which may involve anything from testing AI and looking at different models, is to have governance to ensure a way forward. And so that way we're able to understand use cases as they develop from the beginning. We're able to catalog those use cases and then evaluate them as needed. And in fact, it's one thing that I find interesting is that we kind of set up, or we are setting up a collaborative, a shared AI governance structures, right? Because at the VA, there are hundreds of facilities, right? I mean, there are actually thousands, but hundreds of medical facilities that are not clinics, but ones that are, are interested in investing in AI. And there are regions across the country. And so we've built this structure that builds on that, right? So it scales. So that way we don't have to be looking at, thousands of use cases all at once, but rather we have these AI oversight committees at different medical centers that can scale up to then the regions, that then feeds into the national level. And some of these, we learned interesting lessons, right? We started first with the medical centers. Turns out obviously not every medical center is going to leverage AI at the beginning, right? But some of them want to learn about it, right? So by having this, it's basically an inverse hub spoke. We call it kind of spoke hub model. We, in parallel, develop the hubs at the regions with the spokes, so that way you can elevate and ensure equity across the different medical centers by including the needs of the spokes as part of the development process. So that way we're able to scale in a more unified way. The other piece to think about, so, as was mentioned before, we kind of started in research, right? And of course, research is quite very important. It's a way that we often see if a pilot or something will work, right? And so we've developed, in addition to these AI oversight committees, subcommittees in some cases, we also have these institutional review boards that look and create these supplemental modules. So we're not creating a new process. That's one thing I want to emphasize. What we're doing is leveraging existing IRB structures and adding in these AI modules. And these modules include questions to get people to think about what to ask. We find that one of the biggest challenges is actually knowing what questions to even ask in the first place, right? Once they know the questions, we can be involved in gathering SMEs and so forth to help on that. And through this process, we've actually found actual industry trials and other cases where there was either a lack of transparency or issues in data and so forth. As was mentioned by an earlier panelist, some of these are not even necessarily AI issues, right? They may be privacy, security, those other kinds of issues. But sometimes there's kind of a need to have this checklist to know what to look through, right? And so at the VA, we've developed that for these different parts of the organization, whether it be research, that's the AIRB, or more operational use cases, the AI oversight committees. And then we've also leveraged and worked with other parts of the VA on creating bulletins and guidelines, right, around generative AI. What are some example use cases? What are the risks? What are things to think about? And how it all fits into the trustworthy AI framework. So all of these things we're happy to share. We have shared it already with some parts of the different organizations. And so if people are interested, let me know. Lastly, I know there was a theme around partnering, working together, right? And so I want to talk a little bit about our AI tech sprint that we announced in September, that you'll be hearing about more very shortly as well. And the idea with our AI tech sprint is it's a way for us to potentially collaborate, right? So there's a theme such as ambient voice dictation, such as looking at healthcare worker burnout, those kind of things where we have a competition where people can apply and then compete, and then there's a prize. And then afterwards, as we've seen in the past, we've at times been able then to give winners a contract to kind of continue work. In some cases, being able to justify sole source contracting when there's a national winner. And so there's a number of different avenues. There are different options and opportunities that we've been looking at, novel ways to work together. We've been building an AI network across the country. We have 4 sites, and we announced that we're going to double that and grow more. And the idea is that we could work with academia, we could work with industry, with others toward developing AI solutions and working together to collaborate moving forward. So I think I'll end there, but just to say that, there are a number of existing frameworks and governance structures already that can be integrated and adapted to the use of generative AI. The AI tech sprints that we've been working on are one vehicle that we've been looking at to collaborate and ensure that trustworthy AI is embedded in the contracting language, in the solutions that we leverage and the research we do. And the policy and governance at both the agency and interagency level, right? We can work on these public-private partnerships, and there's an opportunity to do that through our new National AI Institute's AI networks that we've been developing. So with that, I'll close and pass it on to our next speaker.
I'm Catherine Marcassini. It's part of my voice, a little under the weather, but I serve as the Chief Privacy Officer at ONC within the U.S. Department of Health and Human Services. And I also echo the thanks to NAME for the invitation for me to share a little bit about ONC's role in advancing transparent and trustworthy predictive technology in healthcare. Before I dive in, I wanted to check to see, I guess by a raise of hands, who has heard of ONC and or proposed federal regulation that pertains to AI or algorithms in healthcare? Okay, well, my colleague, my ONC colleague, Jeff Smith, is in the room today. So I'm going to do a lightning round, kind of to give you a little bit of background, but please feel free to approach Jeff today. He's instrumental in ONC's activities in this area. Next slide, please. So for general orientation, ONC is the principal federal entity charged with coordination of the nationwide efforts to implement and use the most advanced health IT and the electronic exchange of information, hence our interest in AI, algorithms, models to that effect. We at ONC have three primary areas of activities that align with our overall coordination efforts, really focused on advancing the development and use of health IT capabilities, as well as establishing transparent expectations for data sharing. And as a result, a lot of our activities are focused around standards, as well as certification and exchange. Much of the conversation today will be centered around our certification program, but also coordination. A key part of what our identity is as an office is really centered around coordinating with a range of interested parties within and outside of the government, like NAME, to further progress towards the two objectives you see there on the slide. Next slide, please. At a very high level, the ONC certification program is now foundational to the U.S. digital healthcare infrastructure. For those that are familiar, pardon, you probably have heard these stats before, but currently the certified technology under ONC's program, there's 400 health IT products that are used by 97% of hospitals and over 84% of clinical offices within the U.S., as well as, required by numerous federal programs. So at a very, kind of big picture view, the health IT systems that are regularly certified to keep pace with advances in medicine, technology, and policy, part of our recent interest, I shouldn't say recent, but part of the newer emerging technology around predictive technology, large language models, generative AI, part of the discussion today. Again, ONC's role is to certify technology, and what this means is it establishes a baseline for the technical capability for interoperability, as well as promoting the overall exchange of electronic health information, and also establishing a baseline privacy and security requirements from a technical perspective, in hopes to, also increase the transparency and the functionality and the use of the technology. And, I'll touch on a little bit later about the intersection with the topic today around technical capabilities as well as transparency. Next slide, please. So at a high level, ONC's vision is better health enabled by data. And so I mentioned certified health IT to help, lay some of the context around kind of the intersection with AI. Most people are familiar with electronic health records, or EHRs, when they think of certified health IT. We at ONC know that they play a prominent role in the growth of predictive algorithms, models, AI, choose your term, in healthcare, they serve not only as a source to develop this type of technology, but also as a delivery mechanism for outputs of the technology. And so we have been looking at this area and trying to figure out, how to optimize predictive models in healthcare against the backdrop that, there are many benefits, but we also understand that there are unintended consequences when this technology is either, incorrectly used, applied, developed. There's a lot of ways in which things could go wrong. So you'll see here, some of those areas that we have been focused on. There was a blog series we started, back in, I would say, over a year ago. And so, wanted to share that here. Again, we don't have, a lot of time to dive in, but we are aware of these consequences. Next slide, please. With all that being said, and understanding ONC's role, in April, ONC issued a federal proposed federal regulation, of which a part of it include, some of what you see here, and I'll touch on this, but a lot of what the U.S. Congress charged ONC to do is about certifying health information technology to make sure that it provides appropriate information to help guide medical decisions at the time and place of care. And so what is proposed, or what you will see in the regulation, and the citation is included there, it's really focused on enabling improved information transparency around the trustworthiness of predictive, and we use the term decision support intervention. It's an already existing term under our current regulation to support the widespread use in healthcare. And in addition, I'm touched on transparency, and you'll see there on the slide about what is meant by trustworthiness as well as consistency. We center around making sure that there's information available as to whether or not a user can determine the quality of the technology. And what we mean by that, really, is the output of the technology and the process, that was used, if it's fair, appropriate, valid, effective, and safe, and, FAVES for short. We also, touch on how best to make sure that the certified health information technology addresses some of the areas that are more susceptible to concerns around health equity. So to overall promote health equity by design. Next slide, please. And so a key pillar is around transparency as a prerequisite for trustworthy AI. As mentioned, it's a proposed rule. I don't have the full time today to go through it, but what you'll see here on the slide is we understand that there's many ways that people are trying to tackle the topic of responsible, ethical, transparency, trustworthy. A lot of words, different ways to say this, but we focus around data transparency, performance transparency, performance of the technology, as well as the competency or transparency around the developer of the technology. And you'll see here on the slide what we mean by that. Data, really getting at the type of data that is relevant to health equity, and the information and transparency about whether or not that was used. In addition to, does the technology perform, or what is it designed to do or intended to do? In short, we're proposing to require developers to provide information about what the technology is intended to do, and then also provide or show information about does it do what it is intended to do when they tested it along the way, as well as is it fair in the testing, but also potential risks that should be addressed, could be addressed, that they did address, governance, in hopes that this will help provide an effective and target deployment to inform the user about this. Next slide. Again, just for context, the definition as we proposed as it relates to predictive decision support intervention, to connect it to today's discussion, the definition would include large language model generative AI as part of what we are proposing, and it would not be tied to risk or intended use or how things of that nature. And I know I'm at time, but again, just in closing, I would say next slide, some of the potential benefits that we have outlined or what we see if they are, if the proposals are finalized. It's not only for IT developers, but also patients and clinicians that may use the technology in healthcare delivery, as well as the healthcare industry as a whole. With that, again, a reminder, feel free to reach out to Jeff in the room if we don't get to the discussion in the panel, but I'll turn it over to the next speaker.
Thank you, Catherine. Robert?
Well, first of all, thanks very much to the NAM leadership and to the staff who gathered everything together and has made today such a really productive day. I've been really excited about this discussion, and my mind's just going in a million miles in lots of different directions. So I'm going to try to use my notes a little bit to say what my staff expected me to say. First of all, I want to address something that was asked of us, and that is come up with some practical recommendations. And one of the things that I think we need to come up with and to say to the public is to help calm what may be hysteria or panic, because over the last year they've heard about ChatGPT and GPT and artificial intelligence and all these other terms that are kind of scary. And I don't know, how many of you saw this week that self-driving cars have been put aside in some cities? They've been banned. So, we're talking about this in medicine at a time the public's fear about artificial intelligence is rising and peaking. So we have to keep that in mind as we talk about this and as we report out, because part of what we need to do is to reassure the public that we're really looking out for the future and for the safety of our consumers, the patients that we serve, and others in our communities. It's reminiscent of the arguments and the concerns that I saw in the pandemic when we actually had vaccines developed with a new platform called mRNA. People remember that? All of a sudden it popped up, mRNA. It was an overnight sensation. No, that was 30 years in the making. How about this artificial intelligence, this large language models? Oh, it's only been 70 years in the making. It's been since 1950 when Turing's test occurred, and we've seen waves of advancement in artificial intelligence. We've seen times when there was a trough, and that trough was the result of really the inability to have the computing power and the engineering that was necessary to make that next leap. And while we're talking about large language models now, and there was this discussion earlier today about, maybe having 1 million criteria models, as being maybe problematic or pushing the edge. But if we think of the next time we're going to gather, it may be around the fact that quantum computing is now available to us, and we can do a lot of what we can't do now faster, easier, and actually begin to think about the next phase of artificial intelligence and making that challenge that I make to my staff when I came on board, which was, let's imagine providing 24th century healthcare to all. What does that mean to you? What does it take for us to plant the seed for 24th century healthcare? We can't even get to 21st century yet for many parts of our country. But at least we can begin to imagine what that might look like. And in order to imagine it, we have to begin to have some ideas and goals for what we in fact want out of these tools. How are they going to assist us? Because we're not going to take the human out of the loop. I agree with our previous speaker. We're going to have the care return, hopefully, if that's what our goal is. And we'll have assistance to actually make that an easier thing for us to do so we can focus on the care of our patients. Even in 24th century care, when people will be living on Mars, in the asteroid belt, and on the moon, and other places, in other, perhaps even other universes. But we'll be able to finally get past this hybrid work problem that we have in many of our offices, and probably also be able to figure out how to provide care to people when they in fact are ill. I want to thank Jackie for this morning for reminding us that artificial intelligence is not new in medicine. And in fact, it's used all the time. She said she uses it every day, every time she's in the clinic. She's probably one of the few clinicians who actually knows and recognizes that she's using artificial intelligence tools to help her do it. Certainly in the work that we've done at the Agency for Healthcare Research and Quality, we've learned that many clinicians and most of the public don't know that those tools are already in place. And so some of that hysteria, some of that concern arises from the fact that people are just not cognizant of it, that this is just a new wave. It's a new wave with new and more important implications, as we're talking about today, but it's not something out of the blue, not something to be afraid of. AI has really dramatically evolved over the last 70 years, and I want to thank Jennifer for her passionate reminder that the house is burning down. Healthcare in the United States is in critical condition. And yet we're talking about artificial intelligence kind of in the absence of that context. So one of the groups of people who are not taking part in this discussion, although they've been alluded to many times, I want to thank Michael for inviting clinical leaders, for inviting government leaders, for inviting industry tech leaders, but not inviting the people who make decisions about whether or not we can implement these tools, whether we can invest in these tools, and the context within which care takes place, which are the healthcare executives and trustees of healthcare systems around the country, all of whom are governed by different rules and regulations in their own states, their own territories, or in their tribal communities. They're part of this effort to try to create this sense of trust in what you're doing on the scientific side and what we're trying to do on the science side to diminish that 17-year innovation to application in the clinic area at ARC. That's my charge to our staff is let's try to cut that in half. What is it going to take? How do we take these innovations and actually get them in the clinic sooner and faster? And we're not a regulatory agency, and so we have to convince people of the right thing to do. And we can only convince people if they're calm enough to actually hear the message and to understand how these tools, in fact, can make healthcare better, how they can serve the needs of our communities better, and how they can be individualized now to provide personalized care, that patient-centered care that we often talk about, rather than simply algorithmic care, which generalizes and assumes everybody's the same. Earlier today, one of our speakers talked about the fact that large language models are really about language. They're language-based. Well, I was speaking to someone who was helping build these models, and in my house, we speak Spanish, English, Italian, learned English, learned Italian, and all those simultaneously. And when we start our journey to healthcare, how do you start your journey to healthcare? You probably do what most people do these days, or at least younger people do. You look it up. You get on your computer, you try to find some information. So when you go on that search engine and you're trying to find the information, it depends on your language and that search engine. And right now, in my household, we can ask the same question using our different languages and have very different answers. So, that's kind of like the easy part. That's the start of trying to understand how to use these various tools. But AI has potential, and it has the potential to improve diagnostic accuracy, to improve efficacy in workflows, to improve therapeutic monitoring, to improve procedure accuracy. AI still is in its infancy in its applications in clinical care improvement. But these could be the goals that we strive for and that can help direct where these models are developed and where they begin to be implemented. In the short run, I agree with some of the other speakers, and I think those who we've interacted with at ARC, because ARC's unique mission is to improve healthcare through the generation of evidence, and I've heard the call for more evidence, the distribution of actionable knowledge, and that's what we're trying to do here, trying to figure out what do we actually know and what do we need to know, and help with implementation. How do we, in fact, help people do that? And some of you and some of our previous panelists are trying to do that, bridge that science to implementation area. And that's what we're trying to do at ARC. And the call for evidence and assistance in trying to figure out how to help people implement it is what we're after and what we're trying to do. In the short run, I think we can help reduce the drudgery of medical care, helping reduce administrative burdens and improve workflows, given where we are today with the generative AI. But if we have these other goals and these other missions, in 5 years' time, as was suggested by some of our speakers, we might actually be there in some areas. Generative AI has been a topic of interest at ARC for quite some time, and I'd like to just briefly describe two activities that were currently underway that we're thinking about for the future. We're just about to publish a final evidence review on the impact of healthcare algorithms on racial and ethnic disparities in health and healthcare. When it was posted, it generated a lot of public comment, and these are the findings that, or at least some of the findings that I think are relevant for today's discussion. The effect of algorithms is complex, and some have been shown to perpetuate or exacerbate disparities. Some have been shown to reduce disparities, and others basically have no effect. An algorithm may exacerbate disparities for one outcome, but reduce disparities for another outcome. Many algorithms in clinical use perpetuate or exacerbate racial and ethnic disparities. And a lot of that was the result of bias at all of the life stage of the development of the algorithm, from the beginning, from the thought of who's engaged and who isn't, all the way through how it was implemented. Along with the published evidence review, ARC and the National Institutes of Minority Health and Health Disparities supported an expert panel that's drafted some guiding principles to address the impact of algorithms on racial disparities in healthcare. In May of 23, the panel shared the draft principles with the public in a virtual meeting and took public comments. The panel's concluded that efforts to mitigate bias are important across all stages of the algorithm life cycle. And they proposed 5 principles that should be followed: promoting equity in all phases of the algorithm life cycle, transparency of algorithms. And that's a discussion that we've had here. How do we actually create transparency, and what does that really mean? Authenticating and authentically engaging patients in the algorithm development and its use, and explicitly considering the trade-offs for algorithm use and establishing accountability for equitable outcomes resulting from algorithms. The second ARC activity is really a collaboration between our Digital Health Research Division and our Patient Safety Center to support research on the intersection of AI and patient safety. Patient safety being one of 6 domains of providing high-quality health care. There's strong potential for the use of AI in medicine, but there's also the potential for its introduction of errors and safety issues. While I can't discuss future funding opportunities, I would like to highlight an existing special emphasis notice that's published by ARC, under which studies of various topics could be funded, and this call for additional evidence be found. The notice indicates an interest in funding grant applications in 2 key areas: how the digital healthcare ecosystem can improve patient safety, and how the design and implementation of digital technologies can lead to patient safety issues. More information on these funding opportunities are available on our website. Looking to the future, ARC is really reviewing our existing programs to determine their potential for understanding the impact of AI on patient safety and on quality in general. And these include modifying our common formats, which are used by the patient safety organizations, to address more specifically patient safety events involving artificial intelligence tools. Curating an AI library on ARC's Patient Safety Network, PSNet, as a resource, and using surveys on patient safety culture, supplemental items, which is an examination in hospitals of how they're governing the use of health information technology, including artificial intelligence. As a recovering healthcare executive and trustee, I just want to put on the table a couple of concerns and questions that at least my interaction with colleagues running healthcare systems have raised as a result of the work that we try to do, working with them and convincing them to participate and improve care. Bias, of course, is important. They're concerned that building the kinds of models that we build only is built on people who actually get care. And so we actually don't know whether or not, or they're concerned about the bias of their entire community. They're concerned about how we build and validate. They're concerned about that black box that was raised earlier, and the fact that if you've seen one healthcare system, you've seen one healthcare system in any community. So their context truly matters. And they want to know how the external validity of these models actually works out. They want to know and be able to trust and have transparency. They want to know the level of risk that they as healthcare executives are taking in investing in these activities. And lastly, who's liable when things go wrong? And most importantly, they're most concerned with equity and really understanding how in their communities equitable care can be provided and not biased. Thank you.
Thank you, Robert. And there's a couple of points that I really want to call out from that presentation. One is the integration piece, and I think this is a very relevant topic to where we are today, is how do we ensure that these products are integrated, right? It's not about just the safety and the efficacy, but also the integration into the practice itself. And one thing that I've heard in my current role is that, you know, all this technology is great, but we don't know how to actually integrate this into our day-to-day lives. And I think if anything else, it's causing more stress on the already overstressed medical professional community. The other thing that Robert talked about was the assurance piece, right? The public assurance piece. Yeah, it's our responsibility, obviously, to assure that the products that are coming into the market are safe and effective. But I think it's really incumbent on all of us to think about the assuring the public with relevant and accurate information that needs to be distributed to the medical professional, but also the patient community when they're effectively being treated by something that is assistant with AI, that they should be aware of that. They should have transparency in how that product was actually developed and how it's being used. So on that note, Riva?
Thank you. The tour of the federal agencies has stopped at NIST. We have a lot of lesser-known agencies on the panel today. My name is Riva Schwartz. I'm a member of the Trustworthy and Responsible AI team at NIST, part of the team that developed the AI RMF, and I'm here to talk about it. Who are we first? Who is NIST? NIST is a non-regulatory agency. You don't hear that much in this room, but Robert Valdez had pointed out. We're a non-regulatory agency under the Department of Commerce, whose mission is to promote innovation and industrial competitiveness through advancing measurement science. NIST standards, we like to say, is our middle name, but in fact we do not develop standards. We serve as the U.S. leader for standards in international standard-setting bodies, but we are also the National Measurement Institute, so we're really really all about measurement at NIST. We've been working from the very beginning at NIST to cultivate trust in technology, not just AI, but now AI. And the AI RMF is one example of how we are doing that. So directed by congressional mandate in 2021, NIST released the AI RMF back in the end of January, so not quite a year. The framework is a voluntary, non-regulatory framework for managing the risks posed by AI technology to individuals, communities, groups, society, and our environment. It is not a checklist. It is instead meant to help AI organizations align their internal culture and practices with intended aims and shared societal values, and build up a risk culture, also known as a safety culture, within that organization. This framework is not just for the tech sector or other parts of private industry, but in fact also for federal agencies. The purpose of the framework is to take many of these existing high-level principles that we saw over the past 5 or so years and put those into practice. We spent more than 18 months developing the framework in an open and transparent manner. That's how we do everything at NIST. Many of the people in this room were involved in those activities. Everything we do and everyone we heard from is on our website. In the end, we worked with more than 240 organizations to build a consensus-based framework over 3 workshops and 3 opportunities for public comment on versions of the framework. And again, all of that material is available on our website. So what does trustworthiness mean? We hear that term a lot. What does trustworthy and responsible AI mean? Trustworthiness is far bigger than whether a system functions or is accurate, because functioning and accurate systems can still cause harm. So in the AI RMF, we define trustworthiness with the following key characteristics. And we heard about a number of these throughout the day. I'm just going to focus on a few in the interest of time. First and foremost is validity and reliability. This was actually the hill we were willing to die on during the development of the framework. A system can be accurate, but still cause harm. But validity demonstrates whether the technology is actually doing what it claims to do. That is a much higher bar and much less likely to cause harm in specific contexts. It's important to know that these characteristics, of course, interrelate and come with various trade-offs. Yet right now, we tend to study each of these things in silos. We have researchers who focus on interpretability, researchers like myself even, who focus just on bias, but not really, and people who are focused on transparency. So we try to address these silos across the AI RMF. I want to take a slight detour since I am the principal investigator for bias at NIST, to do a shameless plug for a paper that came out all the way back in March 2022, because I think this gets at this notion of, we've been talking about human-centric versus model-centric. Actually, we haven't really talked about model-centric, but what we tried to get at with this document was to say that right now, we really focus on statistical and computational biases, which is a reflection of model-centric focus in artificial intelligence. And we taxonomized bias into 3 main categories. And as you can see, this is just a sampling of all of the biases out there. And what you tend to see is, right now, is a lot of bias, what I call bias detectives. A lot of people online saying they found bias in a various system. And of course, there's no such thing as bias-free. Bias is all around us. So it's not so much whether you found a given bias. That is to be expected. But what type of bias is it? What category does it belong to? Is that bias causing harm? And how can we manage and reduce it? So how do we do that? In the AI RMF, we do that through 4 core functions. These functions come with 72 outcomes, 72 operational, actionable outcomes that organizations can meet to operationalize trustworthy AI in a culture of responsible practice and use. The govern function is purposely in the center. It is the foundation upon which everything is built. It is where organizations set up the policies, practices, and procedures to cultivate the culture of risk management within their organization. Just like we've done before for privacy and for cybersecurity. Map function is where context is established. We truly believe that the future of AI is interdisciplinary and socio-technical. Managing AI risks is a full contact sport. So we have to acknowledge and take into account that AI systems are broader than the data, the model, and the algorithms, and instead they are a function of the organizations and societies in which they are designed and operate. Central to this is the inclusion of input and feedback from the various, we call them AI actors, engaged in the development, design, deployment, use, evaluation of AI. So not just people along the life cycle, but the person operating it, the people whose data underlie these systems, and the people who may be impacted by them, whether they use them or not. So we can't measure, moving forward, we can't measure in an information vacuum, and yet in many ways that is where we find ourselves. The goal of the measure function is to set up testing, evaluation, validation, and verification practices, but we are really limited by this current model-centric focus. So we ask AI RMF adopters to, using what they set up in the map function, begin to capture and track system trustworthiness from a socio-technical lens. And then the manage function is where organizations allocate their resources to treat the risks that have been mapped and measured in line with policies established in the govern function. So we went one step further and created a playbook. Those of us who are on the playbook team, the framework went away for the day, and then we stayed up at night like little elves building the playbook. Why did we do this? Because we knew that we had a lot of outcomes that we were going to provide, and a lot of companies would say, yep, we do all of those things. So we said, well, maybe not. So we have a playbook with hundreds of actionable recommendations for how to meet these 72 recommendations, 72 subcategories. We also have something we refer to as profiles in the AI RMF. In this, it basically refers to implementations of the framework, either in an organization or sector. Entities are encouraged to develop these alone or in collaboration with others. I know this is a topic related to CHI, for example, and potential for a profile in healthcare. When we released the AI RMF, we also released a roadmap. Note the first top 3 are standards, test and evaluation, and AI RMF profiles. I'm just going to put a shout out here that we are, and this Sebastian's not here, but we're intending to move towards building up a measurement science for trustworthy, responsible AI that considers AI trustworthiness, specifically of AI chatbots within their context of use. So not just from the model performance and its capabilities, but from a human interaction level. And I just want to end with, you can find out, you can see all of our information either on our main NIST.gov page, all of our material, including the playbook, which I am sorry is 240 pages long, but you do not have to read it from cover to cover. It is a reference, is available at airc.nist.gov. Thank you.
Thank you, Riva. And next is Christine, and then after that, we'll just go directly into audience questions. Thank you.
Thank you very much, and thank you for bearing with us. This is the final of the Fed tour. Thank you very much for this opportunity. I'm Christine Cotillo, now recently actually from the Office of Data Science Strategy at NIH, focusing on AI and ethics. And I'm stepping in for Susan Gregoric today, and we'll be discussing some of the biomedical research considerations for AI and Gen AI that we're tackling from the NIH perspective. So back in 2019, the NIH Advisory Committee to the Director formed recommendations that outlined priorities for biomedical AI across NIH. These recommendations outlined opportunities in 3 key areas: data, people, and ethics, that need to be taken together to reach that responsible and ethical AI vision. This report formed the foundation and drove much of the past work in data science at NIH. And just a quick note that a new strategic plan for data science at NIH is in progress and will be released shortly that builds upon and modernizes these concepts based on where the field is today. So here I've outlined some illustrative current challenges and opportunities that the space is facing, and I'll briefly step through each of them to highlight current work in the space and some of the ongoing open research questions to lead into our Q&A. So in terms of AI data, integrating clinical research, healthcare, social determinants of health, and environmental data is critical. There have been a few major programs initiated in past years to address these issues, including Bridge to AI, bringing technological and biomedical experts together with social scientists and humanists to generate flagship data sets and automated tools. It also importantly emphasizes ethical best practices and promotes diverse teams, which is also kind of connected to our workforce development space. Additionally, for the past 3 years, we've been supporting AI readiness supplemental funding aimed at supporting collaborations to improve the AI and ML readiness of NIH-supported data by advancing the ethical development of AI-ready data and bringing together multidisciplinary expertise to make that data generated useful for others. An example of a project on the right that we supported leveraged Gen AI to improve missingness in brain images, enabling a complete AI-ready data set for further analyses. Some open research questions in this area circle around understanding and building out the appropriate diverse roles and processes to make the generation of AI-ready data more routine, in addition to building out the broader corpus of AI-ready data generally to begin to combat unrepresentative data, biased training data, and perpetuation of systemic biases. In terms of AI infrastructure, creating and coalescing tested infrastructure, resources, and tools to support the research community is critical. A key major effort is the National AI Research Resource, or NARE, to create a shared research infrastructure that facilitates access to compute, software, data sets, models, and training for researchers and students. An interagency working group is currently planning and launching the pilot integrating government agencies and industry together, and we expect to see Gen AI as a major component of the use cases in the NARE. NIH has also held workshops in this space recently, gathering perspectives from the community around their needs, such as the NSF and NIH joint AI bio workshop that took place this summer, where Gen AI pervaded almost every breakout session. Ongoing open research questions in this area circle around enhancing the practice of ethical AI model assessment that we've talked about in many of the previous sessions, and bolstering the tools and technologies available to accurately test models prior to and throughout implementation. And that includes practices for continual assessment and assistance to guide that implementation field forward. In terms of responsible and ethical AI, representative data, transparency to assess appropriate reuse of models, and aligning data sets and algorithms to the use case and question are key. We are currently in the process of planning an AI ethics and transparency workshop to gather community perspectives on guidance needed for informed, transparent, and ethical reuse of data and models. meaning what are the key pieces of information that different stakeholders at various stages of the AI lifecycle require to gauge appropriate reuse of both the data and the models. Additional workshops have also been held to understand the research community needs better. We have heard time and again that many researchers want to work toward and perform ethical and responsible AI, but don't feel that they have the needed tools and guidelines to do so. There have been efforts to build generalizable tools to start working toward this goal, such as the NCAT's AI Bias Detection and Mitigation Challenge, where the generated tools are available open source for the community to access, use, and iterate on as a jumping off point. Ongoing open research questions in this area circle around enhancing community-engaged AI practices with end user and community engagement throughout, and increasing transparency into data collected and models developed and implemented. In terms of the workforce and capacity, enhancing collective capacity, coalescing frameworks for the work, and creating an inclusive AI workforce is critical. Landscape assessments of existing methods for research processes and training opportunities illustrate the need for many enhancements. And a major flagship program, Aim Ahead, began in past 2 years to enhance the participation and representation of researchers and communities currently underrepresented in the development and use of AI and ML in this space. Additionally, the Aim Ahead Connect platform is a virtual hub for folks interested in the intersection of AI and health equity. The community are able to go there and find opportunities for mentorship and collaborations virtually through that site. And importantly, NIH is also helping to support the National Academy's AI Code of Conduct study to provide guiding framework to ensure that AI algorithms and their applications in health and biomedical sciences perform accurately, reliably, and ethically. The resulting framework will reflect best practices and serve as a starting point of reference for continual work and improvement in this key area of AI and ML. Some open research questions in this area circle around enhancing capacity and capabilities of broader geographic spaces to lift all boats, not just those of traditionally funded research communities, and increasing training opportunities and expanding the workforce in AI and ethics through things like curricula development and safe platforms. With all that in mind, NIH has also released some guidance and policies around the use of Gen AI and peer review. NIH prohibits the NIH scientific peer reviewers from using LLMs for analyzing and formulating peer review critiques for grant applications and R&D contract proposals. Since any of these materials pertaining to an application or proposal are privileged information, and there's no guarantee of where data are being sent, saved, viewed, or used in the future. Additional open research questions in this area, though, that we're thinking on are these challenges of trustworthiness and explainability that have been brought up previously. Gen AI models can be confidently wrong and can't always adequately give an explanation of their predictions. Also, this scalability that was touched on earlier as well of these computational resources is a big issue. Currently, industry is primarily the source of these Gen AI models since they are too costly for academics to build. So there's a need for improved scalability to democratize and improve responsible and ethical practices across sectors, including industry, so that we balance the appropriate growth and applications of these technologies. And just lastly, some of the most challenging issues in this space, as we've also touched on, are not necessarily technical. So building and increasing the interaction between computer science and other fields, such as cultural, regulatory, legal, and ethical, is needed. So briefly, in summary, there are obviously many opportunities in this broad and quickly moving space of AI and Gen AI. And NIH, along with all of my co-panelists, I'm sure, in this Fed space, aim to support collaborations and new opportunities to develop social and technical solutions needed to support the research community in the responsible and ethical use of AI to reach our goals of improving health for all. So thank you very much for your time.
Thank you, Christina, and my entire federal colleagues for that wonderful presentation. I know it's towards the end of the day. I know we're not feeling the fire that was burning earlier. So let me see if I can actually add a little fuel to it. And by answering the first question that was actually asked in the last panel, which was getting an FDA approval, does that mean commercial success? And the answer is no. It does not mean commercial success. It means that you have clinical evidence that it's safe and effective, but that's a business model that you have to answer, and that's for the folks who in the back of the room were actually wondering about, where they referenced a startup that actually went under, and I believe I know which startup that was, which was marketed, it had a market value around $2 billion when they filed for bankruptcy, and that's something that we have to deal with at this point, but I think that's more of a business problem than actually a regulatory problem. So on that note, I want to open up to the floor if you have any questions.
Hi again, everyone. I'm Lakshman. I wear two hats. So one is at Medicaid in Massachusetts. The other is as a pulmonary critical care doctor at Harvard. So speaking from both perspectives, I really want to I worry that if the FDA is creating approval for certain tools that are going to be deployed clinically, and it's all siloed. If healthcare utilization of AI is siloed in healthcare, I think we hit the biggest problems of them all, because whether it is at the bedside, where people, come on, share PHI all the time on text message that's unsecure, right? Like, this is what happens in real life. People will use the easy-to-use, free ChatGPT in their pocket rather than the one that is a little bit harder to use, requires a workstation, requires logins, took too long to deploy. That is valid. So that's an ethics. Then look at on the managed care side. I'm looking at the health plan and saying, like, oh, help me target the patients who are at rising risk of becoming homebound in the community and senior care population, right? Like, if that algorithm is ultimately trying to please me, it may do those things at the cost of very hard to identify inappropriate denials, right? And like cause patient harm in those ways. So, we will all use in reality, trying to be practical here, the tools that are most readily available, not necessarily the ones that are the most vetted, et cetera, et cetera. So I would urge us to say that the standards we apply here are, like, the health standards need to be for every single tool available to everyone in this country who's using the generative AI tool at the top. Because if it's not, you don't have control. In the same way that, I'm sorry to say, a peer reviewer that can look at a grant for the NIH and use whatever tool they want, we will never know. This is coming up in the art world where like manufacturers of like hobby industry and board games are saying we can't say whether artists are using AI to generate the art. We have no idea. So it doesn't really make sense for us to approach it. It's a very different example, but the point is when you cannot trace it back, when you cannot know that it's being used, don't assume in our ivory tower that people are doing what we write down and ask them to. It's a very real world out there with a burning house and extreme pressure. So when you see fire everywhere around you, you will use the fire extinguisher in your pocket, even if it's fire, even if it's not vetted by all the top standards, because there's fire. And once in a while,
Thank you.
Hi, I'm Daniel Yang from the Gordon and Betty Moore Foundation. I have a question around like the quality of evidence. So we talk a lot about safety, we talk about efficacy, but what I see is that a lot of these algorithms, whether they're LLMs or more traditional analytic AI algorithms, are tested retrospectively, on data maybe from one or a few sites. They're not tested robustly, prospectively, multi-site trials, randomized. And the question here is, like, who funds those trials? So at the Moore Foundation, we're trying to nudge the field forward, but clearly some of these trials are extraordinarily expensive. We've seen, models that say in the United Kingdom, NHS is funding these trials. And I'm not seeing industry fund these trials either. Or if they're funding it, they're kind of funding it more for marketing purposes than they are for independent evaluation. So who fills the gap of funding these robust clinical trials to really demonstrate to the public these are safe, these are effective?
Right. I'll try it, and then maybe the panel can answer that. But I mean, I think what you're talking about the phase 4 clinical trials that are slightly probably handled differently than what I would consider to be a post-market performance monitoring. right? And that's really around, but now it's a little tricky because that's a very different regulatory paradigm than we have currently, right? So if you think about what happens with, any kind of medical product, right, whether it's a pharmaceutical or a device space, is that it goes through a market authorization, then it gets deployed, and generally speaking, we don't really address the post-market performance unless there's an adverse event. And what you're referring to is a slightly different regulatory paradigm and operations where we have to actually have the tooling necessary to continuously validate whether the model is performing as intended or whether it's actually evolved from what it was initially deployed. And that's a vastly different kind of area that we have to focus on. And how we're essentially trying to tackle that is through multiple areas. One is making sure that we are actually working with the industry on the tooling necessary to be able to monitor those things. And I don't think that's a regulatory, it's not just a regulatory challenge. I think that's a best practice that should be implemented with any software deployment, right? And I find it as someone who's coming from the technology side of things, it's very interesting that we're not actually talking about the operational discipline of deploying these models as we would with traditional software. Right? And that's missing right now. And part of the problem is it's probably because it's still in that R&D phase, right? We're very excited about these capabilities, but we're not necessarily thinking about what happens once it's deployed into what I would consider a production environment. In this case, it's a hospital system. So there's two folds to this. One is we have to actually think about the regulation from that angle. It's a different paradigm. And second of all, what tools do we have? Is that purely an FDA requirement, or is that also the responsibility for the hospital system that is deploying it, as well as the model developers, to ensure that these models are alerting when they're effectively changing its response based on the new data that is coming in? Anyone else? Gil?
Yeah, just wanted to say a couple things. So one of the things I think is that we're seeing now, any results that we see now, right? It took a while to create those results, right? And a lot of this research, at least kind of the exponential growth, just happened a few months ago, right? So we're starting to see results that are just a few months, and it takes time to do some of the types of studies that you mentioned, more time than it does to do the easier ones, right? So I think with time, there's sort of this a little bit of an implicit bias, a little bit of bias in terms of the types of studies we see now kind of being published that we kind of see out there. But number one. Number two, I think there will be, what you're saying is a really valid point, and I think that we'll see more of that in the future as people see the potential issues. I'll just give you an example of something we saw at the VA. We're building a model for looking at COVID, right? And it's one thing if you have one hospital and you build that model, but there are hundreds of these medical centers, and as mentioned, like over 1,000 when you include clinics and things. So what we notice is both, is COVID changed geographically in regions, also as different variants came about. The models, you basically have model drift, and the models perform better or worse, and you really had to be constantly monitoring and learning and making and doing the types of things that you were saying to make sure that the model keeps performing. So, there are many papers that came out and they were shown to be not reproducible, in this area in general, when you're looking at one or two sites. But then when you look at, over 100 sites, you can do that, but you have to do the types of things that you were saying to continuously monitor, update the models, and take these different, sometimes hidden variables and figure out what they are and add them in. So that's what I wanted to add in. It's a very good point, and I think we'll see more of that going forward.
Thank you. And we have about 5 more minutes left, so probably about 2 questions. So I think we have one from Lee.
Yeah, thanks. And the context is previous CMO of CMS, so Troy, you won't be surprised at the question. From a deployment in the health system, and I'm really following up on that question. How do we ensure not only the individual algorithm gets right, but we learn as an entire healthcare ecosystem about deployment? We've had problems where people said for 20 years, Bob, that we haven't improved safety. I think we have, but not as much as we'd like to. How do we ensure that learning? Where is the trusted national resource to look at deployment of AI?
Yeah, that's a great question, and let me answer it this way, and I want to keep it short to get to Peter here. But I think that it's beyond the responsibility of the federal government to actually come up with those risk management framework, right? So the way I always look at it is there's a risk definition, and then there is the management framework, and the definition is really what is the risk associated to applying this? And the framework is really around how to make a decision to where you want to apply it, because you can standardize the model itself, but the risk profile of each medical system is going to be vastly different. And I've seen that in the past. But what we have to do as an industry, and when I say industry, we're one part of that ecosystem of the industry, is come up with both the risk definition and the framework and then push that. But the hospital systems have to actually contribute to that, right? And they have to agree on both the framework and the definition together. It can't be just done by either the federal government or the industry by itself individually. So that would be one of my recommendations, but that's going to require a lot of coordination also from the industry to also agree on what those risk definitions and the framework is.
Or I was going to add to that. I mean, I guess in short, there's maybe potentially a lot of parallels that could be drawn to the information security arena. I know, like, for example, there's ISAC, so information sharing and analysis centers that are set up across different sectors to where there is collaboration, particularly around, the owners and the operators of certain, if it's technologies, facilities, and that, to kind of add to Troy's comments, I think, potentially there could be a parallel for, AI in healthcare. The other piece being, I guess, just to double down on about the measures and, what is the threshold. A lot of, we were very specific in our federal proposals about, we know that there's a lot of activity and interest within industry around, standards developments, the tools that you're going to use to test. The fact that there are a lot of standards, there's a lot of measures. But, to Troy's point about, the government or, whose role and whose responsibility, I think there is a lot of activity or interest that, the industry should be playing to help kind of do more of a, I would say, self-regulatory approach around some of this, and then, the government's happy to participate, but agree that there is a role for industry to play.
Thank you.
Great, thank you. Y'all hear me?
So thanks, Peter Emby from Vanderbilt University Medical Centers. Just wanted to maybe pick up on the comment Gil made just now to Daniel's question and also the broader question. So, operationalizing algorithmal vigilance and monitoring that. I mean, we're still learning, to your point, and even in places where we're trying to operationalize that, there's still research to be done. So I totally agree. But bringing it back to generative AI, I think it's an even less clear sort of process in terms of what we need to do. So I was just wondering how you all have been thinking about that, recognizing it's very new. What are the similarities and differences in terms of the algorithm of vigilance when it comes to generative AI?
You want to start? Yeah. Well, I guess I'll just quickly start, and maybe we can go down the list. But for me, it's quite different, right? I mean, one is a closed kind of system. It's static in many ways. It's very similar to software, right? How you deploy software, where it's iterative. And I think where we're having to think through this, but the reality is, I just want to also make this comment. It's been around for 6 months, right? So. Really generative AI, well, at least ChatGPT 4 came around March of this year. So we're also trying to catch up to kind of what this thing is as it's also evolving as each day goes. So from our point of view, what we're having to think through is the kind of the multiple level evaluation framework that has to factor in that the foundational model and the application might be two separate companies with two separate disciplines in developing software. That's how we're having to think through it. So what we're actually asking, and this is where we need a lot of, I would say, private-public partnership is how do you even audit these things? What is the right methodology for auditing them, right? I mean, I think we have a pretty good idea of looking at traditional medical products, even to a degree, predictive AI. Right, the way that we evaluate and approve them. I think generative AI it's a different paradigm. It's pushing all of us to kind of think differently, and that includes the regulatory practice. What I can say is that how we've been communicating with legislators that the post-market performance monitoring, in this case, is much more important than the pre-market authorization. That's where it changes. That's where it's very different than how FDA had generally approved medical products in the past. And that's the point that we're trying to make. So that means that your regulatory authority has to be effectively change that for generative AI. Yeah, exactly.
Yeah, what I want to say is first just to give an example of how it's radically different, right? If you type a search query into Google, you type it in, a millisecond later, you type it in again, you'll get the same answer. But if you type in the same thing into the generative AI, you'll get actually a different answer. So anything with model, any of those things, they happen immediately. And then, of course, over time, it will change as well, right? So it is definitely an order of magnitude more complex. So what we've been looking at is first focusing on operational use cases that are internal to the VA for those. So there's an employee, someone who gets to see that output. It isn't directly presented to the patient or in some way. So that human in the loop, but essentially first focusing internal, and many of those use cases can make a huge difference, right? Those back office, those use cases, and where we have someone who can judge it for hallucinations, all those different issues, and then looking at, potentially, what could be done in the future for patients, but right now kind of focusing, there's many other types of AI other than generative AI, obviously, right? And leveraging those types for the patient-facing ones.
I would, I guess, also add ONC and the current authority. We actually have surveillance, and basically, there's an organization that works on behalf of ONC, and they're required to conduct ongoing surveillance activities to assess whether the certified health IT is not only meets the requirements of the certification in a controlled testing environment, but it also includes when the technology is implemented and it's used in a production environment. And I know we don't, have a lot of time, but, as I mentioned, our current proposals would include generative AI as we propose the definition, even though we use the term predictive, but just wanted to make note of that as well.
Well, thank you, Catherine. And I know we're at time at this point, so I want to thank you all for the engagement. I also want to thank NAM leadership for making this all happen. I actually came to the government because I really wanted to take advantage of the government as a whole, the muscle that we have in order to addressing this very complex problem. But very shortly after I came into the government, I realized that this is not going to be done solely by the government, and that it's going to be done by all of us working together and as equal partners. And I just want to encourage all of us to take away that very point. Thank you. All right, well,